Steve and then Michael.
I enjoyed the panel presentations and perspectives. Thank you very much. Steve Ruberg here. Bob, you talked about helping people by providing recommendations and EMRs and things like that. Micky, you were critical of HITECH in some of the ways it's laid out, and is it really going to help us achieve the goal? And I guess I'm dying to hear from you guys. How can HITECH help make this happen on a national level? How can this board or what can this organization do to make this work, not just in the greater Cincinnati area, or not just in, but across the nation? What role can we play? What advice do you have for us that would bring users together, physicians together, patients, consumers, whomever, to make this work? I'd really appreciate hearing your thoughts and perspectives on how we can help.
Okay, that's the $64 question, $64 billion question. First of all, you have to recognize that there are different jurisdictional levels. Lori and I have had this conversation. You know, is it state? Is it region? Is it local? And the answer is it's all three. Clinical care is local. I mean, that's one of the weaknesses of the NHIN, if you're thinking about it for just the clinical support process. How often does that happen? We have had a focus, you know, very much in the clinical medical service area. Our weakness is on the health plan side. We need to have a little bit bigger footprint, which we're beginning to address by some of our expansion. Many other things, and what Lori and others have been, and Micky and others have been able to do at state level is very, very impressive to put in the overall infrastructure to make it work. But thinking through that at those three explicit levels and understanding the difference of where you give the money and what you're trying to accomplish would be a big piece of it. The people will go to their normal patterns of making things happen. And if you go to a specific jurisdiction, they're going to think in terms of their jurisdiction. We have very much of a medical service area that crosses 3 states. And there are specific examples I wouldn't like to give here that show that you really have to be able to, I mean, for syndromic surveillance, germs don't stop at the river, even though the boundaries of what different organizations think about do. So we've really got to be able to address that and to make that work.
Well, I guess it's hard for me to answer what HITECH can do, but it's just, I mean, it seems to me that as a sort of a multi-stakeholder collaborative organization that can help through that kind of multi-stakeholder expert process, it helped to inform policy to the extent that you can start pointing out some of, assuming you agree, that there's some serious policy issues that we still have to contend with here. This isn't done. That HITECH and isn't the last word on this, and indeed, I would argue that the odds that the Congress could have gotten this right on their own. I remember how this happened. This was, before the administration had really, sort of gotten all their people together and really had a voice in the whole process. And and to their credit, I think they did go ahead and created a whole bunch of stuff that's really good. And so I don't want to be overly critical, but the odds that they could have gotten it right the first time around without this kind of broader deliberation are close to zero, right? So so it seems to me that being a part of that voice that can help inform policy and help more and more people recognize that there's still some policy issues that we need to confront, and that this, like any other huge kind of policy change in this country, you have to iterate a little bit, and helping to inform ONC and helping to inform what the policy changes need to be to improve this, I think would be an incredibly valuable contribution from my perspective.
This is Will Russ. I wanted to, Stephen, thanks for the question. I think that HITECH is already having an impact and is leading in the right direction in that there needs to be a larger dialogue than just a federal dialogue or just a state capital dialogue. And that's what I would ask for from HITECH, is to keep reminding the country that it's not federal and it's not state, it's local, and it's all of the above. And the amount of coordination we need to accommodate local variances is a key to the success of this particular effort. If we go into this with the assumption that we can just distribute some dollars, we're going to be disappointed. we really need to be coordinated. And one of when I read the legislation, I was pretty disappointed at what, from my perspective, living in a rural area with a lot of small health departments, it was almost like the health departments didn't exist when I read the legislation. And when I looked at the coordination, in our local safety net community is composed of 6 FQHCs, 9 rural health centers, 3 Indian Health Service clinics, 1 VA satellite clinic, and 5 emergency rooms at critical access hospitals. Well, you can't put that together when you look at the legislation, but that is the local cohort. And so advocating for appropriately operationalizing the funds that we have and the resources that are at our disposal is really a key. I think that as a public-private partnership, as external to the federal government, NEHIC is in the key position to enable this process to succeed.
Yeah, hi, it's Mike Lardier, and I appreciate the presentation. The question I have is, if we're looking at an incremental approach, and if I'm going to advise providers of where to start, what, in your opinion, is the best place for them to start as the first building block in order to move towards meaningful use? This is Will Russ. I'm going to say that the very first thing providers need to understand is their own workflows and and an inventory of every external source of incoming data that they are going to have to address. Because at the end of the process, every one of those manual or paper-based streams is going to have to become an electronic stream. And if they aren't starting with a coherent picture of the as-is workflow and the inputs that have to be converted and a destination to be workflow, they're going to be disappointed if they're just going to buy something off the showroom floor and drive it off the lot.
So a couple things. I guess, first I would tell them to wait until at least mid-June until we have a little more information on what meaningful use means and hopefully a little bit of a better sense of what is a certified EHR, because, you don't want to go down the road of purchasing, a very large hulking system if that's not what you need at the end of the day to get your incentive. The second is, and the advice that I give to individual physician practices at talks that we give in Massachusetts on this is to not do it alone. Do not embark on this on your own, because if it's doing it through your IPA or your PHO or your hospital has a Stark Safe Harbor kind of program, or some other kind of collaborative, you got to do it as a part of an overall program, because for any practice to do just what Will described on their own is incredibly hard and incredibly challenging.
John? This is John Tooker. I just want to expand the conversation a little bit about the dealing with small entities that need to acquire health information technology, but looking at it not so much from the point of view of those that are providing the care, but those who are receiving the care. So that if you are a patient in one of the communities that Will has described, and I thought the presentations were really excellent, you will like to be interfacing with a small entity that is your ambulatory source of care, a small hospital, maybe a small long-term care facility now. And it seems to me that we are just highlighting the divide between larger entities' ability to adopt faster and how long that it may take for smaller entities to get in the game, if they're going to get in the game at all. And part of this may be, of course, the networking that Bob talked about that allows some economy of scale for people to feel part of a bigger entity. But it seems to me that it's more complex than that when you look at the scale of the adoption needs in this country. I think in the 2005 or 2006 ambulatory care survey, there was something like 900 million ambulatory visits in this country, most of which occurred in small settings now. So can you help me a little bit with about are we going to be able to protect and to provide critical success factors for smaller institutions to play in the game as well as the larger integrated health systems?
Ms. Will, I just wanted to, well, thanks for the question, John. You're really asking the realigning reimbursement incentives question. And there's not much we can do from the technology side if the individual practices have no incentive to collaborate. I see a health information exchange living in the network space between these enterprise boundaries where they have no incentive to take care of the interface. And it's up to us to carry the data from point A to point B. And until there's an incentive to collaborate, vertically integrated organizations like Kaiser just rock because they've got all the incentives internally. And when you get to a little tiny community where nobody has a direct business relationship, and their reimbursements actually discourage them from collaborating, that's really the elephant in the room here. We can do so much with technology, but we can't force that to happen.
The 900-pound gorilla is sort of pushes back on the health information exchange piece of this, and they tend to think that they're closed systems. I'm actually sitting in a place where I can at least measure pieces of that. Well, we own that group, so they're using us. Not so much. So we really look at it as an opportunity to bring in the small hospitals and let them, to a small extent, ride on the coattails of the larger ones that have built the network with a sliding scale based on annual expenses. So it's really very cost effective for the smaller hospitals to get in. We have one rural hospital that is just putting in their first electronic system. We haven't been able to do anything with their paper, but they'll get there fairly quickly, we think.
I would agree with Will that I think that the issue here is about interoperability being something that everyone wants to do, rather than feeling like it's something that's being imposed upon them. And it's either through strong incentives or compulsion. If for example we had a way of saying that you are absolutely not required, you are not allowed to not send a consult report back to the primary care physician who referred that patient to you. But you're not allowed. You have to send it back, and it has to be structured in some sort of way, and not specifying that it has to be electronic. I think you would start to see that the different organizations, like they do in every other industry, would say, all right, well, now that I have to, I can't send 10,000 faxes a day. Where is that health information exchange? Where's the Bob Steffel that I can say, all right, I'm going to be able to do it now much more cheaply because now it's a cost of doing business, and I'm forced to do it. But right now, there are too many organizations. I think too many hospitals, too many specialists, too many primary care physicians who don't feel the need to do that. Oh, I'll call them. I'll bump into them here, and I'll tell them that everything's okay. To me, that's the fundamental problem.
Paul? Just real quick, I don't think you're implying this, but obviously incentives and directives aren't going to be enough. The technical support, the information overload that practices feel in terms of trying to figure out what's the first step, the inappropriate application of technology in the offices that we saw, even when people try to do things, is pretty amazing. Even some innovative things like two-way pagers were used inside the four walls of the same practice, 5 feet apart from each other, as a way of communicating. So you take something like that, a good idea that might have made sense when there was a hospitalist or somebody in the hospital, and do that. Now you're using it for inter-office communication 5 feet away. So I think there's that. I don't think the incentives are going to be enough. It's going to provide the hand-holding, the sort of don't do it alone, real important, especially in the small practices who are struggling.
Okay, here's some good news. When you're in a marketplace where there is really a critical mass of participation, different effects take place. I had a physician come to me, this has been like 10 years ago, and he'd just gotten clinical messaging. And he said, Bob, you've got to get everybody up on clinical messaging right away. I said, well, why? Why is that, doctor? He said, well, yesterday, one of my office staff had to go and get a chart and fax something, which he'd been doing for 20 years, right? But now that was just unacceptable to him. And he's just thinking out loud, and he said, oh, you know what? I'm going to call Jim and tell him that I can't do any more referrals to him until he gets up on clinical messaging. So there's an expectation within the physician community for this to happen.